I am going to give a short talk on triple B regimen, which stands for Basal Bolus and Booster Insulin Regime. It's a new project which we are going to implement in Tawam Hospital for the better management of inpatients' hyperglycemia. It will also help the physicians who are not specialized in diabetes care management in their daily practice. Slide 1. Most of the patients who are admitted to the hospital due to acute illness, they have many reasons for getting hyperglycemia. They have increased release of stress hormones like epinephrine and cortisol, which antagonizes the insulin action. Some of the patients are on steroids, or they are being started on steroids during the inpatient's management, which will lead to hyperglycemia. The patients are not on the regular diet they are taking in their home, and there is a change in the diet pattern, and some of the patients are on enteral or parenteral nutrition, which leads to fluctuation of the blood glucose levels. And above all, there is a decreased level of activity. So these all factors leads to hyperglycemia, which has a deleterious effect on the body. It decreases the immune function, increase the oxidative stress, there is increase in the inflammatory markers and fluid electrolyte imbalance. And it can potentially exacerbate the myocardial and cerebral ischemia. So we are traditionally using the sliding scale insulin, and we are used to it. Now we want a transition to a new regime of triple B, and we have enough evidence which shows that outside the critical care area, sliding scale strategy is inappropriate. And we have many studies which have proved this statement. The basal bolus provides the result that most closely resembles the physiological pattern of over glucose control. So if we are going to implement this regime for better outcome, we need close monitoring. It is time consuming, probably at higher cost, and above all, there is a risk of hypoglycemia. So we need the selection of the patients on which to implement this scheme, this regime. So the inclusion criteria includes the length of the stay of 4 or more days. So if the patient is having a less than 4 days stay, we can still use the sliding scale if the patient has hyperglycemia. The patients who have uncontrolled blood sugar, and we should know that these patients should not be critically ill. We exclude the following patients: the patients with the diabetes, ketoacidosis, patients already on a higher dose of insulin, more than 3 units per kg body weight, gestational diabetes, short stay patients, patients on steroid therapy, and patients who are on dialysis. We refer them to these physicians who are specialists in diabetic care. So this is a busy slide, and here we are going to discuss how to implement this regime. The hospitalized patient with hyperglycemia who are not critically ill, we should measure the glycated hemoglobin, also known as hemoglobin A1C, on admission. It has a dual benefit. It will give us an idea of the glucose control in the preceding 3 months, and also it will help us in the diagnosis of diabetes in those patients of hyperglycemia who are not known to be diabetic. After that, we divide the patient into 2 groups. The first group is a patient who has type 1 diabetes, insulin requiring type 2 diabetes, and newly diagnosed hyperglycemia which is persistent during the hospital stay. So we further divide them into 2 groups: the patients who are NPO, means who are not taking any feeds, and those patients who are on feeds, who are taking their regular diet. So patients who are NPO, we usually start them with basal insulin dose. If they are already on insulin, we continue with the same dose or start it with 0.2 to 0.3 units per kg per day. And we have 3 insulins: NPH, which is given every 12 hours, Determer, which is given every 12 to 24 hours, and Glargine, which is long acting, and we give it once in a day. Plus we add the correction dose of insulin if their fasting pre-meals blood sugar is more than 150 milligram, and we start with 1 to 4 small dose, which we are going to discuss in the next slides. So aim of using the correction dose is to prevent the hyperglycemia during the hospital stay. It is similar to a sliding scale insulin which we were using before, and we can even use the regular insulin 6 hourly as a sliding scale which we are used to, which we are accustomed to. The patients who are eating and their blood sugar is fine, we continue with their regimen, insulin, which they are taking at home, plus oral medications. If the blood sugar is uncontrolled and they have hyperglycemia, so we start them with the Basal Bolus regime, and as I described in the previous slide, we have 3 insulins: NPH, Determer, and Glargine. Now, because these people are taking meals, they need insulin to cover that meals. So if they are eating 3 times a meals, we will give them 3 times short-acting insulins, and we have different types of short-acting insulins like Humalog, which is also Aspart, Glulicine, and we start them with a low dose of 0.03 to 0.1 units per kg per day, and then we divide them into the 3 doses. We then add with it correction dose of insulin, and for correction dose of insulin we check the pre-meal blood sugar. So for the aim of adding correction dose of insulin is not only to prevent hyperglycemia post-meal, but also to get an idea of the daily requirement of insulin before the patient is being discharged. If the blood sugar is not controlled and the patient is still NPO, we increase the basal dose of insulin by 10 to 20% every 1 to 2 days to achieve the blood sugar targets. And also we can add the correction dose of insulin. If the patient is eating, also we can adjust the basal and bolus dose to bring the sugar to the desired target. So if the second group, now I am going to talk about the second group, patient with diabetes on diet or oral hypoglycemic therapy. If these patients are NPO, they are not taking any feeds, we discontinue oral agents because it can lead to hypoglycemia. And if we can add the correction dose of insulin if their blood sugars is more than 150 milligram, and we can check the blood sugar 6 hourly, and we can adjust the insulin in the following days. If the patient is eating and the blood sugar is well controlled, we continue the oral agents. If there is no contraindication and glucose is well controlled, but if the patient has a poor control of the blood sugar, then we shift them to basal and bolus regime. And again we use the same insulins as I have mentioned before. For basal dose we use NPH, Detamar, Arglargine, and for prandial we use Aspart, Glulicine or Lispro. And then again we have to add the correction dose to prevent hyperglycemia and also to know the need of insulin during the hospital stay of the patient. If the blood sugar is not controlled and the patient is NPO, we can increase the basal dose by 10 to 20% according to the blood sugar readings, and also we can increase the correction dose of insulin, which I am going to discuss in the next slide. If the patient is eating, again if the blood sugar is uncontrolled and not in the desired range, we can increase the basal and bolus doses after every 1 to 2 days. And we should get an idea from the correction dose of insulin how much is the requirement of the patient, and we can divide that dose into 50% into glargine and 50% into the prandial dose, and we should add the small units, 1 to 2 units every 2 to 3 days to prevent hypoglycemia. The correction dose of insulin, which I have mentioned in previously, we have divided them into 3 groups. The first group is patient with type 1 diabetes, lean patient requiring less than 30 to 40 units of insulin per day, and patients who are prone to hypoglycemia. We start with a very small dose of 1 unit for each 50 milligram increase above 150. So if the patient has 150, more than 150, we add 1 unit. If the patient has 200, we add 2 units. If the patient has 250, we add 3 units. And the second group is a patient with the type 2 diabetes, overweight, requiring more than 40 to 100 units of insulin per day. So we start with a higher dose of correction dose, 2 units for 150 milligram, 4 units for 200 milligram, and 6 units for 250, and similarly for higher blood sugar levels. The third group is the patients who have type 2 diabetes and who have severe insulin resistance requiring high dose of insulin of more than 100 units per day. And those patients who are taking steroids, we go for a higher correction dose of 4 units for 150 milligram, 8 units for 200 milligram, and 12 units for 250 milligrams. For correction dose of insulin, we always use the pre-meal glucose check to prevent hypoglycemia, and also we advise to check the blood sugar at bedtime. So in the end, this is conclusions and recommendations. Although data from studies in glucose control in medical surgical wards who are not critically ill are lacking, we recommend a blood sugar pre-meal of 90 to 140 as reasonable. That is why if the blood sugar is 150 and above, we add the correction dose of insulin. Rigorous glucose monitoring and control in hospital requires supervision by trained and knowledgeable staff. And the aim of this presentation is to bring awareness among the staff. It is important that diabetes should not be ignored during hospitalization, and insulin therapy should be initiated where required, with frequent adjustment to optimize control, as I have mentioned before in my talk. To make it easy for the physicians, there is in the Cerner, if they add triple B or just add triple, or even if they add insulin, this page will automatically appear in the Cerner. And as we can see in the blue, it is written here insulin triple B protocol. And this is the further details of the slides. If they want to start the glargine, the dose is already there in the system and it will automatically appear, and it is written here point, and also the criteria of inclusion and exclusion is mentioned in the previous slides. This is for further for boluses regime, and the dose is already there in the system. This is again the dose which we can give every before meal, and it is already in the system. And after that completion, this page will appear, and it is showing above consult diabetes education. Once they enter in the system, automatically it will go to the diabetes educator, and insulin regime which has already been fed to the system will appear, and it will be very easy for them to just implement them. And also blood glucose monitoring, down we can see also it will appear in the system to check pre-meals and at the bedtime.